So welcome to our first session. This is session A4, Innovations in Care Delivery, Improves Quality and Saves Cost. I'm Greg Ogrintz. I'm the chair for the session. I'm a general internist and the senior scholar for the VA Quality Scholars Fellowship Program at the White River Junction VA and at Dartmouth Medical School in New Hampshire. We have three presentations for you this morning, and the format that we'll use is each presenter will have about 30 minutes total, and as each presenter comes up to present, each one has about 20 or 22 minutes of prepared comments, and that will allow for several minutes of questions after each presentation. And then we'll switch to the next presenter, and if we preserve some time for the end, we will finish with a panel discussion with our group over on the stage. So as you're listening to each presentation, prepare your questions and think about what you might want to inquire about during the question and answer session. We're going to hear about three different presentations today, and our first presenter is from Stockholm, and Fjellner. It will come to the lectern, and I will have you introduce yourself, each of the speakers, with your specific professional background, and then you begin your presentation. Welcome.
Good morning, everyone. I'd like to thank you all for coming here, listening to me and our project in Stockholm County Council. I also would like to thank one of our leading politicians, Mr. Stig Nyman, who is sitting here. He's chairman of one of our subcommittees, public healthcare subcommittees. I also want to thank, of course, all the staff members in the acute care hospitals, Gunilla Benner-Forsberg, my right hand, as we say in Swedish, and Joachim Wehr and his scientists for the results we are going to present today. I'm one of the senior medical advisors in Stockholm County Council. I'm a general practitioner from beginning, and I've been working in this healthcare administration the last 9 years with different kinds of development projects and improvement works. Stockholm County Council is the most populous county in Sweden with more than 2 million inhabitants, and our healthcare is publicly financed. As you know, there are a little amount of our patients who are frequent users of the healthcare system, and especially frequent users of the acute care healthcare systems, our emergency departments. And I will show you our latest results from these randomized controlled trials. The results are so new, so I haven't minded them yet. They are analyzed last week, and yesterday and during the Saturday and Sunday too. You know that 1% of the population within Stockholm County Council accounts for 30% of total healthcare spending. And this is the same results as in other healthcare systems as well. Many of these patients have frequent ER visits. Our results from large-scale RCTs indicate that the nurse-driven case management contact program, delivered primarily through planned telephone support, can increase quality of life and substantially decrease healthcare consumption and costs if the right patients are targeted. Healthcare organizations can expect high return in terms of improved quality of life and reduced healthcare costs of strategies that support patients with frequent ER visits and high per capita healthcare costs. We had some hypotheses we would like to test in this improvement work, and that's why we choose to use a randomized controlled trial. And patients with complex healthcare needs and high per capita healthcare costs often don't receive the healthcare they need at the right time and at the right care level. And here again, I will draw what do you say in English? I will probably talk some Swinglish sometimes when I don't find the English word. But we listened to Maureen just before this session, and she talks about what matters for patients. And this is what matters for patients. An individually customized nurse-driven contact program that proactively reaches out these patients can improve cost-effectiveness of care and quality of life for these patients. In Stockholm County Council, 1% of all adults in Stockholm County Council account for 30% of total healthcare spending, 48% of in-house healthcare spending, 25% of all emergency admission, 64 contacts with healthcare providers every year. And those high consumer patients, only 15% are high consumers the year before the study. And 1/3 of these patients is younger than 65 years old. Can a well-designed nurse-driven contact program reduce the need of emergency care for these patients and improve quality of life? The intervention we wanted to be evaluated was identification of patients with high risk for future ER visits through develop a predictive model and qualitative screening. The patients met the nurse in one structured in-person consultation with a specialized case management nurse. Thereafter, regular support through planned telephone calls focused on coaching and establishing necessary healthcare contacts outside the ER. And this study designed with control group and intervention group. Questions about the study I prefer to receive from you after my presentation, when I can have help from the scientists. The endpoints evaluated is readmission frequency, inpatient days of stay, healthcare costs, and quality of life. 3 comprehensive randomized trials evaluating this case management model are carried out in Stockholm at the moment. We have these frequent ER visitors, adult visitors, patients with more than 3 ER visits during the past 6 months. And we have results from full 1-year follow-up. We have patients with congestive heart failure, patients who during the last 12-month period have been hospitalized more than 2 times due to their disease. And we also here have results from a 1-year follow-up. The third group is patients with chronic obstructive pulmonary disease. Those patients have been diagnosed in inpatient or outpatient care during the last 12 months. And here we have results from a preliminary 3-month follow-up. We have some promising results. And the frequent ER visitors, now we have results from more than 500 patients. And the patients has had their interventions for at least 1 year, as well as the control group are followed at least 1 year. We see significantly reduced days of stay per patient year, 48%. We see significantly reduced doctor visits per patient year by 6%. Significantly reduced healthcare costs per patient year, 39%. And significantly increased self-rated quality of life. Patients with congestive heart failure. Here we have some troubles with our results. We see large variations in results between different hospitals. And we have limited effects on self-rated quality of life. This probably caused by the course of the disease. These patients are in the end of life of their diseases. Patients with chronic obstructive pulmonary disease. Here we also have reduced days of stay per patient year with 32%. Although the doctor visits seemingly unaffected. But we have significantly reduced care costs per patient year with 26%. The follow-up of self-rated quality of life has not yet been conducted in this patient group. We turn back to the frequent ER visitors, and you see the age distribution, median 64 years old. We have a dominance of female, with almost 2/3 are female. In this study, the oldest patient is 94 years old, and because it's adults, the youngest is 18 years old. And here are inpatient care consumption among these patients. And you see in total days of stay per patient is reduced by 48%. And we have both a smaller number of care episodes per patient, but we have the huge reduction of length of stay. Thus, these patients visit doctors outside hospitals more than before when they are not consuming inpatient in-house care. No, they don't. These doctor visits constitute of both primary health care and somatic health care open visits. And you see as well here there's slight reduce in doctor visits. And the costs for the county for this targeted group is reduced from 17,800 euro to 10,800 euros. And it's a reduction with 39%. The patients are rated their quality of life with using SF36 before they are included, or in the when they are included, after 2 to 3 months, and about 1 year afterwards. And you see there significantly rise in self-rated quality of life. We have this problematic target group, patients with congestive heart failure, and we have some results we don't yet understand. We have to analyze the data further, but there are differences between 2 of the hospitals. In current days, we have more hospitals, but we don't have results for more than 1 year for those patients. We have this third group, patients with chronic obstructive pulmonary disease. And here we have only a 3-month follow-up. But you see, for these patients, here again we have a female dominance, median 72 years. And here we have also reduced the number of care episodes, days of stay by 32%, care episodes per patient by 28%. The length of stay is almost the same. We don't see any differences in outpatient care either. In this target group, we too see reduced healthcare costs for the county with 26%, from 14,500 euro to 10,700 euros. Now, all of our acute care hospitals in Stockholm County is involved in this randomized controlled trial. And we have 4 programs, 3 for adults, 1 for pediatrics, and more program is going to be set up in the next month. This is the upscaling we are intend to reach 4,000 patients by the end of this year. And in just 2 years, these case management programs have gone from a promising idea to a concept covering almost half of Sweden's population. And Sweden's population is 9.3 million inhabitants nowadays. And you see, we have Stockholm County Council, it's the east part, clustered points, and through the west coast. And by that, I would like to thank you all for listening. Thank you.
So we have about 10 minutes for questions, and there are 2 microphones, actually 3 microphones available in the aisleway, so please stand up and make your way to a microphone, or if you raise your hand, you're here in front, I can bring this microphone to you to ask a question.
I will ask Joachim Wär, who managed this project in behalf of County Council, to help me answer these questions.
Are your nurses based in hospitals or in general practice?
All nurses are based in the hospitals, and the reason for that are two. One, that's the only way where I can identify the patients really quickly, because we have found that that is one key success factor. You have to identify the patient almost when the patient is in the ER or released from the hospital with a chronic diagnosis. The other reason is that to control the concept and really get momentum into the concept, it would be very difficult to have the nurses placed in 270 primary care units in Stockholm. So there are two reasons.
Could you please in detail describe what the implementation process was for the care concept?
I will not in detail describe it here because we don't have the time, but as Anne told you, the concept is to identify the patients very rigorously and to then meet with the patient. The patient is basically invited to participate in this program. Meets the nurse once. There, the consultation is during, according to a very specific protocol that we are following up and also developing further. And the rest of the contacts is telephone-based, and the frequency of the telephone calls are really determined on the patient's risk to be readmitted. So every telephone call stops with a nurse evaluating the patient's future risk. And that seems to be the key difference from the traditional way of thinking.
Thank you for the very good presentation. It seems like you have a very good accounting of the... from over here. It seems like you have a very good accounting for the costs saved with the patients, but what was the cost of the intervention itself?
Right now the intervention is delivered in a sort of scientific way. Our indications is that the cost of the intervention is somewhere maybe between 1,000 to 2,000 euros per year, which is 1/5 to 1/10 of the savings that you saw here.
So if I've well understood, this program is based on hospital participation, but the patient you've selected have some chronic diseases, so GPs are very important for that. How do you involve GPs in the follow-up of this patient?
One of the main interventions the nurses are delivering is to make sure that the patients are really, again, taking care of the GPs. Because remember, we are identifying patients on the system level here. Many of these patients have this type of pattern of frequent ER visits or frequent readmissions because the primary care contact is not really working. So this is a way of identifying. The entire goal is to get the patient back in a functioning primary care, open specialized care setting. And I would stress this fact that this intervention is temporary. We now see that normally 6 to 9 months after the patient is enrolled in a program, the need to continue actually does not any longer exist. So the goal of the nurses is to really make themselves redundant.
Can you tell me what risk how did they stratify? Did you use a particular risk stratifier in terms of how many calls, the follow-ups? What tool did you use to determine the follow-up calls?
The follow-up frequency of calls. To make a long story short, the nurses are working with a risk prediction model which rates the patient from 1 to 5. And it's a combination between a qualitative and quantitative assessment. The quantitative part is the healthcare statistics of the patient, and the qualitative part is just, what do I hear the patient say and not say in my phone call. We are following up the nurses every week, so every nurse gets her own statistics on how many patients that are readmitted, and they can link that to their risk stratification, so they get feedback on their capability to predict.
And is that something you created, or is it I mean, because you obviously use what we call cost data, something from the centrally. Did you create how you put those pieces together?
Yes. And the advantage of the Swedish healthcare system is that all healthcare statistics are very, very nicely covered to the personal number. So we can follow patients sometimes 10 years back, even if that is not interesting. But on a weekly basis, you can actually see what is the total healthcare consumption of an inhabitant in Stockholm throughout the entire system. Diagnosis, level of care, interventions.
Is it the same nurse who enrolls the patient as follows up, makes the follow-up phone calls? And then how many patients does each nurse have, and how many nurses are there?
Yes, it's the same nurse that enrolls and is the program manager then. And right now, a nurse can handle somewhere around 50 to 75 patients.
In the results for ER, when you looked at the non-consenters, their costs were much lower. That's not true for the other things, but for the ER were much lower, and nearly the same as the cost for the people who had received the intervention. That might imply that if you rolled this out routinely, you'd be overestimating the savings because the non-consenters, who are quite high proportion, were much lower cost. Does that tell you that there's some more work to do on the prediction rule for the ER intervention?
There's always more to do on the prediction. That's the most interesting part. But we have analyzed this both in an intention to treat models and then per protocol models. And now we see significant cost reductions either way you analyze it. But it's very interesting which type of patients that actually say no to this type of program. And that's the part that we're working with very much also, because the non-consenters are a very special group. I can tell you their mortality is extremely much higher than all other groups.
Thank you very much.
Morning, I'm Sarbjit, and you'll see on here that Ian Sturgess was due to present with me. He's my lead clinician for this piece of work, and unfortunately he can't be here, so I'll be presenting this, but take away anything that you'd like me to take forward with him to, and I'll take that back to England. So I'm just going to talk to you about a piece of work that we've done in the NHS Institute. My way of background is I'm not a clinician. I'm a manager. I've worked in hospitals in England, and I'm one of those people that has in time been under significant pressure in those roles, and especially now for managers and leaders in the NHS in England who are under significant financial pressure. It's unprecedented in the NHS, and we know the picture globally, the economic recession and the temptation to go towards the bottom line to achieve savings in healthcare. We have significant public sector cuts in England, and that is really hitting hard on the NHS. So what I'm going to present to you today is something that we did in the Institute. Ian and I did together with a team of people and with NHS organisations, where that really wasn't at the forefront of our mind. We were absolutely focused on delivering better quality care for emergency adults, and how can we do that? How can we achieve that? And actually, when we produced what I'm going to talk to you about, we realised that when we started to cost it, and think about the potential significant cash savings that could be achieved as a result of delivering better quality care, it was significant, and we had to recalculate it because we didn't quite believe the numbers. So I'm going to share some of that to you, and it is, in our minds, it's a true case of when you absolutely focus on delivering better quality. It isn't anything that's soft and a bit of a concept and you can't really hook onto. It is something real and tangible. And what's really at the heart of this is the benefit for the patient. And of course, it makes the working experience of staff who manage emergency care a bit more bearable than the current pressures. So I'm going to talk to you about some of the challenges that we have in England. And you may have these from your own areas that you've all come from. And there's no change to this, even though the financial year is, the last one is 2008-9. Each year it is growing. But you can see there the trend, the rise in emergency admissions in England continues to rise year on year. The emergency attendances to emergency departments in England tipped over the 20 million last year. We have a population of 60 million. That's 1 in 3. Just for those of you where I can help inform the picture that we're in England, it's just to set the scene. Okay, and I just want to present something to you here. Is the number. So in 2008-9, we had 5.4 million emergency admissions costing the NHS 9.4 billion. Now we say in tariff payments, and that's the payment arrangement that we have, and that's the income the hospitals receive for admitting and managing those emergency patients. That's huge. But when you start to look at that number in England, we realise, okay, well, 27% of those have a length of stay of 0. That means they did not stay overnight. And in the same year, another 31 had a length of stay between 1 and 2 days. So if you think about that, there's a large proportion of emergency admissions coming into hospitals that are not staying very long at all. To continue with our challenges, and we know this globally as well, we have an ageing population. The number aged over 90 will have doubled since 1995. Well, it actually did double up to last financial year, just hit the new year. The largest group of adult emergencies are the frail older people. And in 2010-11, 40% of those admissions were patients who were over the age of 65. Okay. We know, and many of you will know much better than I, if you're a practicing clinician, that these patients are the most vulnerable and amongst those at greatest risk. And we call it institutionalisation. And what we mean by that is they are the greatest risk of being dependent on care. And so for those of you who heard Maureen's keynote speech this morning, which we talked about Esther and her becoming dependent on care, she was sort of spiralling downwards. And we know that a lot of elderly patients are being admitted into hospitals, and yes, they may come in with lots of different needs, but they're not always health needs, and hence the need to work collectively beyond health. And as a result of them becoming typically dependent, not all, but a large majority, they obviously then experience a longer length of stay in hospitals. And with that comes the risk of further complications for those patients and a greater risk of mortality. So I just wanted to show you this because this graph, and it's hard for you to see some of the numbers, but I'll just explain it. This graph shows the picture of the length of stay of emergency admissions in England over a year. Okay, so along the bottom are the length of stay in the number of days, and along the top are the volume of patients. Okay, and when you look at that, if you just look at the orange circle that I've sort of highlighted on there, you'll see, just exactly as I was saying a little bit earlier, there's a large proportion of emergency admissions that stay for a very short period of time, and you have to ask yourselves, why is that? What is happening with these patients? That means that they're coming in, and within 48 hours they may be going back out again. So what is the system doing? Then there's a group in the middle, that green circle there, and that's a sort of mix between general and specialist types of patients' needs. And then we, of course, have what I was talking about earlier. Typically, the complex patients, the majority of those will be elderly. That yes, they do come into hospitals and they are admitted, and they may well have complex support needs, and they have a long length of stay, as you can see there, trailing. But how much of that is hospital-based decompensation is what we would ask. And when we look at those, if we look at the orange, what I'm going to talk to you about is the potential and the opportunity of managing more patients in an ambulatory way. What that means is managing them on the same day without admitting them to stay overnight in hospital. What is it that can be done to ensure they have a safe and better experience and better care? And as I said, that's what drove this piece of work. And we call that ambulatory care. So when I talk about that, if you think about surgical patients, planned surgical patients, they come in to a day unit for planned treatment. This is exactly the same. It's just for emergency patients. It's two sides of the same coin. So when I talk to my family, you know, just quite passionate about this, I talk about this. I talk to my family about this and say, wouldn't it be great that if somebody came in as an emergency, they were managed on the same day? And they would go home on that same day. Wouldn't that be great? And I get the nods because they understand the chaos that an emergency can cause to a patient and their family and their carers. The green circle, those patients that stay on average between, say, 5 and 12 days, we did, it wasn't a scientific audit at all, but it was just a snapshot insight into the sorts of patients that would stay that long. And we found that it was just in 2 hospitals, but we found that over a set period of time, 50% of their stay in hospitals was waiting, just waiting for something to happen. So that's quite interesting. So this is what we produced. It's a product, it's a directory of ambulatory emergency care for adults, and it contains 49, and I'll talk about 49 at the moment, clinical conditions of patients that we have identified that can be managed as in the same day, and a proportion of those, and I'll just explain a little bit about what it is, and then move on to the table about it. So these 49 conditions we know are conservative already, because there are a lot of patients that we have not been able to include within the directory, like the elderly, patients who are admitted from care homes or residential homes, because we haven't got the robust data to put that in. So we know that we haven't got the full picture, and it could be much more. But the ones that we have got, they're conditions that are found that are currently admitted to hospitals. And I've explained about thinking of it on a par on the same way as you think about elective planned surgery. When we say it creates a virtual ward of patients under ongoing clinical supervision, what we mean is that what has to be in place is the safety processes for that clinician to be able to make that decision when that patient arrives in the emergency setting, to be able to send them home or back to their usual place of residence or somewhere back into the community or whatever it might be. The focus of this has to be what is in place to continue their support, and has that patient, one, is it safe to send them home on the same day? Secondly, have we got the right support in place to manage them, and do they have, you know, our doctors' own mobile numbers if there's a concern, or if they have any questions that they can ring straight back in if they wish to do that. So, and that's really important, because if you think about a typical, in England, a Friday evening in an emergency department, one has to be sure that the staff, the doctors there in the emergency department, are confident to be able to make such decisions, and they have to work across organisational boundaries to be able to do that with this piece of work. So what we say is ambulatory emergency care is about transforming emergency care. It is about looking beyond the roles that people are currently appointed to in the roles, in the jobs, in the organisations that they're in, and stepping out of that, just as Maureen was saying, and thinking beyond. And it requires a certain characteristic to be able to do that, as a courageous leaders to be able to do that, and to support the staff to be able to do that. It absolutely depends and relies on prompt senior clinical decision making front of house. We say that, we mean in the emergency setting as the patient arrives, for the clinician to be able to make an assessment as to whether that patient is potentially ambulatory or not. So every patient may have the potential to be ambulatory or not. They need access to timely diagnostics and clear care pathways. And, you know, let's not think that the frail elderly patients cannot be managed in this way. They absolutely can and do better for being managed in this way. Now, some of you may think, well, you know, we haven't got the room, this is great, but, you know, we haven't got an ambulatory facility. What does it look like? And how are we going to move patients there when we've got the emergency department? And for diagnostics and radiology, well, you can forget it. And what I would say to you is that our experience of walking around emergency settings across England has shown us that it really is possible. Where there's a will, there is a way. If it means, and I know this, if it means that a patient comes into an emergency setting and the team really want to manage them on the same day, but they haven't got this fully kitted out facility for them, they have actually changed the patient into a gown in the nurse's office. I said, come with us. We know we will manage you today and you can go home today. Isn't that great? They'll manage them in the nurse's office, change them in the gowns, send them to radiology so that they get prioritised and get their test results back on the same day. You know, where there's a will, there's a way. I've seen another area where it was a storeroom in the emergency department, and they converted it, they changed it. They started with two beds and somebody there to be able to observe these patients that could be managed in an ambulatory way. And that's how they start. And once you start to get the momentum, because the clinical teams, and it's multidisciplinary, can absolutely understand the benefits for all the patients. And then we think about the finance by default. So this is what is contained within the directory. This is just one page. And you can see there on your left the conditions, typically like DVT, deep vein thrombosis. We code them, so in England we have healthcare resource groups of diagnosing that condition for which the hospital gets paid. And there you see the percentage potential ambulatory care of being greater than 90%. So there's a range that's in here that's been put in to ensure that it's not saying absolutely, because there are other issues that you have to consider when you're managing emergency patients. Then in the middle, you'll see specific safety issues to consider as the clinicians, and then the link to the evidence base, and that is for every single condition that is in the directory. So I'm talking about delivering better quality care at the time when you need to do it for the patients to be able to manage them better. And then when I said think about the finance by default, that sort of falls out as a result. And this picture just sort of illustrates that, about the opportunity. Our typical bed structure or the flow of our patients in England will look like the upper circle, okay, where there's a shorter proportion of short stay and a larger proportion of long stay patients staying greater than 2 days. And the goal and the aim, if you look at the lower circle, is to reduce the overall occupied bed days and to increase the proportion of bed days occupied by patients staying 2 days or less. Because if you're not admitting them to beds, then further down, it actually releases hospital capacity. So opportunities, again, if we think about this, that there's, when we looked across England, we recognised that there's a large variation. It ranges from 28 to 64% in the number of patients that are admitted via emergency departments requiring a short stay. So something's going on there. This is not attributable to demographic differences between regions or the patient's presenting condition. We know that 60% of adult emergencies should only require short stays from the work that we've done. And if 75 hospitals in England who are not achieving that at the moment, even if they made a 25% improvement, that would result in a 529 million saving in payments. We've produced this guide. It's a how-to guide, how to implement ambulatory emergency care. And it really just provides a tool for the clinical teams to know where to start, who to engage with, how do they do it, and what are the experiences of the organisations that we've worked with, and what are their email contact details, so that it's supposed to, it's intended to be really useful to help people to do that. This graph just shows you what the productivity opportunity has been as a result of ambulatory emergency care. So across the bottom, if you just think about across the bottom, are all the acute hospitals in England that deliver emergency care. Okay, across the top is the volume of patients that potentially could have been managed in an ambulatory way. The light blue is the minimum potential, because we've got a percentage range, the minimum to the maximum, and the dark blue is the maximum. And you can see, you can just imagine across all those organisations, there's huge opportunities, and of course, there's the variation too. I'm just going to talk this through with you, that what we did is, when we started to cost out what does this mean as well from a financial point of view, that when we looked at the first 6 months of 2010, April to September, we mapped out all the ambulatory emergency care admissions, all spells in England. What were they? And there were 721,920 patients. Okay. Out of those, already, there are 209,000 that are already zero. So we take those out. On top of that, there was, I'm not saying it is happening, but there was a potential to convert a further 262,604 patients to be managed on the same day in an ambulatory manner. That is 36%. And when you look at that and you think, well, what does that, wow, that's quite significant in terms of volume of patients. What potential savings could that have meant in terms of payments? It would have been in the region of 300 million. Now, the analysts that did this piece of work for us, they said, you base this on 6 months, and we've just extrapolated it ×2 and for the year, so you get 300 million. But the first 6 months, there's always a seasonal dip for the first 6 months, so your numbers are already conservative. Remember I was saying about the 49 being quite conservative already. We know there are many more patients that could be managed in an ambulatory way, and we're revising the directory, we're updating it to include that, and we don't include a lot of elderly patients who are admitted from care homes. So what we've provided is this web link, and it's an ambulatory emergency day case rate indicator. And what it is essentially is, in England, any hospital or any service, any patch, any community could click into this link, and they could see what their opportunities are, and you can even drill down specifically to the condition to maximise what you want to do. When we've been working in England with a lot of organisations about how best to take this forward, there was a lot of discussion and a real pull from our clinical teams in England to say, we're really struggling with this because there's no appropriate payment in place for managing patients in an ambulatory manner. Our commissioning people who are holding the purse, they're sort of confusing that with, is it outpatients, or are you admitting them, or are they an A&E attendance? So we're only going to pay you for that. But actually, it's a lot more than that, because you're bringing everything to the front, the diagnostic intervention, the clinician's intervention, any treatment, a case management plan. All of that is coming to the front, and it has to be appropriately costed. And so organisations in their own patches across England, they were just negotiating their own tariff, and we pushed hard for a national tariff to be introduced. And I'm pleased to say it's a combined approach between the College of Emergency Medicine and ourselves to represent the clinical and the economic impact of ambulatory emergency care that we've got this tariff in place. We've also I'm rushing a little bit because I know I've only got 5 minutes, so I'm just going to be fairly quick on this slide. We have a delivery network that we've set up, and that is about where we brought organisations together, and they have clinical support, and we work with them virtually as well, and we share and get the momentum and get the movement going for ambulatory emergency care. And here's, I won't read all of this, you can have a look at that. It's what some of our customers are saying about the network that we currently got going, which we plan to run again. And then I'm going to mention this to you. It's about, we call them critical success factors, but you know, if I was you, I'd relabel that and call that my checklist, because I would really urge you to think about some of these things that we've written here that absolutely need to be in place, and you have to push for them, and you have to get the right people around the table to make this happen, because you're relying on the whole system, not just in the hospital sector. You're relying on something much bigger than that, and that takes people out of their existing jobs. So convert it to a checklist, and that's based on our experience. And just to finish off with, I'm just going to show you a little patient's view.
My symptoms were sickness and diarrhoea, very high temperature, and a swelling from my toes right up to my groin. I sent myself off to A&E, saw the doctor in there, where they then start running their tests, and then it was diagnosed as cellulitis. I was prescribed tablets and an IV in my arm, and then they said, if you're quite willing to go, you know, to be discharged and go home, and have the district nurses come out to you. And then, if you're happy with that, you know, please do so. So, which I did. And then I had the district nurses they came around for, I think it was possibly 10 days, to give me tablets, change the dressing, and to give me my IVs. I'd rather be at home, in my own environment, rather than being in a bed that, to be totally honest, didn't really need to be in. I went back to my doctors after that, and he said, if you're quite happy to go back to work, do so, go back to work, but if any problems, come back and see me.
We have about 6 or 7 minutes for questions.
Thanks. I had 2 questions. One was more on the clinical side. A lot of people, particularly of the age group you're referring to, have comorbidities, so looking at individual conditions might be it's more difficult to work out. I wondered if you could talk about that. And the other thing was about savings. It might make care more cost effective, but you only really save the money if you then get rid of the beds.
Yeah.
Because those beds will be filled by other patients. And if the tariff goes up, actually your costs, your overall spending would go up. So I think we have to distinguish cost effectiveness and actual cost savings in the system as a whole.
Yeah. Thank you. Absolutely agree with you about the elderly and the comorbidities, and for that to be managed, and that's why we say that it's really important that it is a multidisciplinary approach to the way these patients are managed and cared for, and that's including social care or anything else that would need to be included within that. With regards to the savings, I absolutely agree with you that they can only truly be realised if the capacity is then taken out. And in theory, one can understand and project what the potential income reduction could be for a hospital. But the moment that starts to be signalled to the hospital that actually the commissioners who pay you will only pay an X amount, there will have to be decisions made about prioritising ambulatory emergency care. Yeah.
Did you look at, when you did the data analysis on this, the impact of weekends and bank holidays?
Yeah, is this with regards to the proportion of patients that could be managed in an ambulatory manner?
Yeah, and how do you get them out again when the services may not be there 7 days a week in the community?
Yeah, no,
how do you get round that?
Yeah, you're absolutely right. You know, That is a common challenge, and we recognise and know that not all services work on a 7-day basis, and it's about encouraging. What we've tried to do through our network is encourage local organisations to get together to decide and agree how they're going to prioritise managing these sorts of patients, and therefore what changes will they have to make to their local services to deliver it.
Well, thanks. I work in Exeter in the southwest of England, and but one of the things I wanted to say was that although you might not need to get rid of beds, you might actually be able to admit elective surgery into your beds, because the major problem that we have is that because of the massive influx in medical admissions, means that as an anaesthetist or an intensivist, I'm standing around in with empty operating theatres because I can't bring my elective patients in because all the beds are filled with emergency admissions. So all the hospitals in the country are being really badly affected. I mean, I think the main problem is that we need to think about getting the GPs back to working 7 days a week, I'm afraid. I mean, we gave them in the NHS, we gave them a 30% pay rise and said don't bother working at night anymore, and that's just led to the NHS grinding to a halt in hospitals because we're just getting all the patients being admitted and we can't get any elective work done.
It is about whole system working. It is about stepping out of the current boundaries that we're all in to work collectively to understand what everybody can contribute to it. And absolutely agree with you, there are a number of possibilities that hospitals could consider when they're thinking about using up their capacity, and absolutely that could be increasing the elective activity.
Sarbjit, that was extraordinary. If this concept is so good, why are we struggling in the United Kingdom to roll it out? What are the barriers for this to be happening in every district general hospital in the United Kingdom or elsewhere in the country or world?
We have pushed. The first version of the directory came out in 2007, in March 2007, and we're updating it now because it needs updating, and we have pushed really hard to ensure that there are national levers that can make this happen. So let's try and move away from locally hospitals and commissioners who pay, trying to have negotiations about understanding it for a start, and then costing it, and hospitals feeling they're getting a fair deal, and commissioners feeling they're paying less than admitting them into hospital. All of that has been really, really challenging and tricky. But I think we've got to a point now where, as an institute, we've got the support and the engagement and the work with the colleges, so the Royal Colleges. So in England, we've got the Colleges of Emergency Medicine, the Royal College of Physicians, that we're in an arrangement with them to make this mainstream. We've got the national payment structure, the national tariff that's just come out this year. It will be expanded on and be developed for next year, and those discussions are underway. And in a way, that will focus people's minds to think we're going to have to make this happen. We have our national clinical director in England. We have national clinical directors for certain areas, and we have one in emergency care who's pushing this hard with the chief executive of the NHS to make sure that this is the priority of how are we going to take the pressure out of emergency care as it is at the moment and deliver better care, and the way forward is ambulatory emergency care.
I've got two questions, actually. The first is whether you've got any data on readmission rates on people managing ambulatory care. And the second is how ambulatory care impacts on primary care and people who have been admitted to hospital. Because presumably, if you manage your patients so well in ambulatory care, patients would probably want to come to the hospital rather than go and see their GPs. And if you prioritise patients in ambulatory care, then the group of patients who are waiting in hospital for investigations will probably have to wait for longer.
Okay. What I would say is that when we look at what types of patients could be managed in ambulatory emergency care, it's being really clear about what are the measures that we need to put into place to be sure we're doing the right thing. So are they receiving are they having their CT scans on the same day? Have we got the right people making the right decisions? And so we can measure that. But we also say measure the unintended consequences. What's the balancing measure? And one of those will be the readmission rate. Okay, so we absolutely need to be sure that we're looking at the full picture and being sure that they're not actually then coming back in as an emergency. With regards to impact with primary care, as I said, it's about understanding what the hospital can provide, but then, you know, maybe for the first time, as I've experienced, one of my clinicians in orthopaedics, for the first time in 30 years in his career, he picked up the phone and spoke to his local nursing home. They were getting a lot of patients being admitted, and it's about and he was a bit nervous doing it. It was quite interesting for me. And he said, once he made that phone call to them and said, well, let's talk about how we manage these patients, it's like breaking down those barriers. And finally, with regards to prioritising ambulatory emergency patients at the expense of others, that absolutely wouldn't happen, because you're in a way, you're identifying them when they come into the emergency setting, and you're managing them appropriately. And not at the expense of the other emergency patients that need to be admitted in. That's about the clinical processes that they set up in the emergency setting. But valid points.
Hi, I think probably what I'm asking is reflected in a lot of other people's questions, and so in some of your answers. But isn't this a little bit of a workaround problems that have existed in the department? So, for an example, did your work look at this high proportion of 0 to 1 day's length of stay, lots of patients that weren't even admitted within that time scale? A lot of that is due to the fact that many departments are managed by very junior staff out of hours, who will err on the side of caution and admit a patient, and then when the seniors come in the following day, decisions are made to discharge those patients. So there will be something around the time of day people have presented. And I think equally, are we then encouraging the public to use the emergency department for conditions that actually primary care could be providing that care alternatively in the community? So I guess my question is this a bit of a workaround to those problems that we know exist? And as a consequence, are we still trying to work on those issues at the same time as treating some of these patients very appropriately and on an ambulatory care basis?
My view on that is that these 49 patients, these clinical conditions that we've identified, these are patients that predominantly are being admitted into hospital. So they're going further downstream, okay, even if it's for 1 day, 2 days, 3 days. And what we're saying is understand why that is happening and identify a proportion of those that you can bring to the front of house, that you can bring to your emergency setting, and you can manage them with the right staff and with the right access to diagnostics that you need to do to manage them safely. So in a way, for me, it isn't a workaround, it's about understanding at the moment our emergency care systems tend to admit we're under significant pressure to push through in, and we're saying bring patients back, bring them back forward. And I can't remember your second point, sorry. What's your second point? Yeah, sorry, thank you for reminding me that point. And I should have mentioned this when I presented, that the sorts of patients that we're talking about here are those patients that are emergencies, that are clinical emergencies. And even if they've had, we have long-term conditions, diabetes and heart failure and all those things. And if those patients, we're talking about only when those patients have a clinical exacerbation and they have to be in an emergency setting. So we're not talking about that category of patients that can be managed better in primary care. We're talking about clinically emergency patients and what are we doing with them at the moment.
Thank you very much.
Well, hello, my name is Michel Katz. I'm from the Netherlands. I'm actually a policy advisor at the hospital group of Twente, ZGT we call it. I worked there now for 3 years. My background is industrial engineering and management. And for the last 3 years I've been busy with tactical planning and helping introducing this new planning concept within the hospital. Well, a bit in line with the questions we just heard about when in our emergency department we reduce the length of stay in the wards. What are we going to do with that capacity in our wards? What I'm going to show you now is maybe some tools also to get insight in the effects of the shortening of the length of stay, but also what can we do with that capacity and how can we react to that. So in fact, with lower costs, how can we still deliver high quality care? Now, to give you a bit of picture of where did we actually implement this tactical planning concept, I'll tell you about our hospital, how big it is, what we're doing there. Afterwards, I give you some insight into tactical planning, because tactical planning is, you can position it between the strategy of the hospital, so the strategical planning, and between the operational planning. I'll show you a nice framework to get a bit more insight that we're all on the same level and we all know a bit where we're talking about. Afterwards, I want to give you immediately some real concrete examples on how we are monitoring the capacity and how we try to steer on them. So you get an example of me in the orthopedics department, and then afterwards I'll tell you something about the organization of the tactical planning. Who's involved in it, who is participating in that program. The insights I'll give you into that tactical planning, so the graphs and the pictures, you could say it's a first level of tactical planning and a second level or first generation of tactical planning, just by looking backward and forward, what is there to come and what can we do? What can we do to effectively make use of our capacities? Then the second level, I would call it integral optimization of our capacities. We know we have an OR, we know we have some wards, but how can we efficiently make use of them? And instead of optimizing one of the three departments, the outpatient clinic or the OR, we try to optimize the three of them together at the same time. So then you kind of create empty capacity, which you can close down on the long term, or you make use of it in a different way. Now at the end I'll give you some results. I didn't make it financially, but at least you get a bit of picture of what the effects can be within your hospital if you focus more on tactical planning. And afterwards, of course, some time for questions. Excuse me. Hospital Group of Twente. Well, it's a region in Holland. We consist of 2 hospitals which merged already 10 years ago. We're teaching hospitals, more than 3,600 employees, 200 medical specialists, which are not on the payroll. Some of the people say that's an advantage. Some people say it's a disadvantage. We have about 500,000 of outpatient visits a year and more than 37,000 admissions in the wards. Well, the total number of clinical beds is around 600, and with clinical beds I mean real beds that are staffed with nurses. Because physically, of course, your hospital probably built 5 or 10 years ago way too many patient rooms. Now, at least in our hospital, we have kind of overcapacity in physical rooms. But that's why we talk about real beds that are open and staffed with nurses. Now, the total region we are providing care to is about 300,000 inhabitants. These are the 2 hospitals. Later on I'll show you where you can find them in Holland. The first hospital is the Hospital of Almelo. We have 10 ORs and 2 daycare operation theaters. Actually, 8 of the ORs we're now currently using. They're good for about 20,000 admissions. And our other hospital in Hengelo, it consists of 8 ORs with also 2 daycare ORs. And you see we have a little bit less admissions there. We also have a fewer number of beds over there. Here we are. People who are familiar with Holland probably know Amsterdam. You go completely to the right, near to the German border, and you'll find our 2 hospitals. Maybe there are some colleagues from Enschede that's completely on the border near Germany, and we're just a bit more to the left. Here the 2 cities. The city of Almelo has 72,000 inhabitants, so it's a mid-sized city. It's not a huge city like Paris, but still there's a hospital to provide the care to the people over there. In the total in Holland you have 100 hospitals, and the trend is that in the next 5 to 10 years that will probably go down to 60 hospitals. So hospitals more and more make choices what they're going to do, And in line with that, when you make choices, of course, it also has effects on the capacities within your hospital. The tactical planning was introduced 3 years ago, and one of the aims was matching actually demand and supply of the healthcare, demanded and also provided by the hospital. You also want to try to optimize the capacity, and we wanted to give insight in how we actually use those capacities. Behind that, although these are nice aims, of course there was also a financial driven factor that was asked by the members of board to introduce the planning concept. But the main result actually of more steering on your patient stream is that you improve actually the flow of patients within your hospital. And the biggest difference is that we don't make decisions now on just finger feelings. You really try to get objective data to support your decisions. And what is completely new, and what you probably before didn't do, is that you try to get an integral view of the total process of the patient in terms of capacity. And you no longer try to do some sub-optimization. Here I show a nice framework. It's made by Aaron Hans. It gives a nice view on the different planning levels and capacities within a hospital. And I show you this because probably when we talk about planning, maybe your neighbor is talking about the patient that is coming tomorrow, and we have to do something about the planning because I want to go back at 3:30 and we have scheduled a patient at 4 o'clock. How are we going to solve it? And when you talk to another colleague, he's talking about the planning for the yearly checkup of the OR. So that's a much longer term decision or planning question. In this framework, you make a distinction between the medical planning of the patients and also the tools you need for those patients. You can do some resource capacity planning, and that's actually what I will be talking about with you. So the ORs, the wards, but also the consultation rooms within the hospital. You've got the material planning, like the scissors, the drilling machine, a CT scan. And finally, you've also got this financial planning, which is often based on yearly accounting rules or monthly reports on how are we doing it. So we focus on the resource capacity planning, and in the resource capacity planning you make strategic choices for the next 1, 2, up to maybe 5 years. Are we going to build an extra OR, yes or no? And once you build it, it will be there for 5, 10, 15, probably 20 years. So that those decisions are also made by the members of the board. Afterwards, we find a tactical planning, a bit lower within the organization, and also the planning terms is much shorter. You'll be about between 1 month up to maybe 1 year, half a year, 1 year. So that is the focus we will have with this tactical planning project. Not for tomorrow, but within 1, 2, 3 months. Then afterwards we've got the offline operational planning. That's the planning for next week, for example. We have to schedule the patients that are coming in the operation room for an elective surgery, and we're going to call them that they have to be there. It's kind of operational, but already 1 week in advance, so we can still make some alterations. And what you see, the further down we get now, the fewer the possibilities there are to steer actually your capacity. And also the possibilities to get extra staff or to send some more people home because we don't need you next week since we see there are no patients coming. And at the end, we'll have the online operational planning. Really, today the patient is coming. In the emergency department, all of a sudden we get 20 people entering the door. How are you going to handle it? That is something you won't be able to change with tactical planning. You have to realize that on that level you always need your operational coordinator at the emergency department or at the OR. So we're right in between there. And to make it a bit more concrete, here we find the strategic level of the hospital, where we, as a hospital, make appointments with our insurance companies. We're going to do 1,000 hip replacements this year, and about 500 knee replacements. And then afterwards, we immediately went to the operational planning. Next week, we plan one hip on Monday with Mr. X, and next week, Friday, we do a cataract for Mr. Y. And in between, within our hospital, we didn't really adjust our different capacities. And what we tried to do with the tactical planning, we tried to adjust the supplies of our capacity, so the consults, like I say, the OR time, adjusted to the demand, like the number of waiting lists we have. If we see the waiting list go up, then it's a signal, hey, there are more patients coming, we should actually increase the available capacity on the OR for them. What we also have is some specific appointments with our insurance company that people with cataract operations, they should get a consult on our consultation hour within 1 week, and then afterwards, within 2 weeks, they should get an operation. So in order to be able to really monitor that and also steer on those appointments, you have to monitor it closely and adjust the capacity in case you don't fulfill the appointments you made with your insurance company. For so far, the level at what we're looking with tactical planning, now I'll give you an example. What are we actually looking at? Because, like I said, we try to look for the whole patient process. And you could see it like a care path. Because the patient is entering the hospital, we have X number of people getting in. They will go to our consultation hours. And from those consultation hours, a certain percentage of the people will immediately go back home, or they come back another time for a revisit. A part of them, they go to the OR. We put them on the waiting list and we say, probably within 3-4 weeks, we'll give you the operation you need. For our OR, we have a waiting list. Well, you could say that's a kind of buffer in order to be able to plan our ORs full. Not enough is not good, too much is also not good, because then the patient is waiting too long. So you've got an ideal number of patients waiting for your OR. And that work in progress, how we call it, is actually all the planned patients at this very moment and all the patients still waiting for an appointment on the OR. Those patients, they will be planned in the available OR capacity, and then afterwards, not shown in this graph, of course, they will make use of the daycare facilities, or they go to the wards. And afterwards, you're completely cured, we hope, and you go back home. The example I give now is of the orthopedics, and what we saw over there is that we had a high access time at the outpatient clinic. There were also some major problems with the planning of the OR patients, and not the problem that there was not enough OR capacity, but the problem was that there was too much OR capacity. And probably familiar, if there's too much OR capacity, most of medical specialists don't want to give it back, because it's my OR capacity. Don't touch it. So what do we do actually? We're looking together with them, and I'll come back to that later, on what is actually happening at their consultation hours. We show them a graph with the number of people actually waiting. If you will understand this graph, everything afterwards will be easy. So let me take some time to explain it to you. What we see over here is for all the new consultation appointments at the outpatient clinic, the number of people waiting with the bars. So there are about 330 people waiting for an appointment. They know they will be treated next week or tomorrow, so they have their date, but the medical specialist did not yet see him or her. From those patients that are waiting, we're looking at the time they still have to wait till the medical specialist sees them. And that is shown by the graph. And we always look at the 75% of the graph. That means that 75% of the patients will be treated or will be seen by the medical specialist within 21 days. So he has still maximum, the patient has to wait 21 days. There are also, of course, patients that don't want to be seen very quickly because next week I'm going on holiday, please see me in the beginning of June. Well, if you look at the 90% line, so that's almost all the patients for the new consultations, they have to, the latest patients, let's say patient number 90 out of the 100, he has to wait about 42, 45 days. So that gives you an impression. If you want to get an appointment pretty quickly, you can. If you don't want to, you just wait. Now, 3 weeks, we say it's average. In Holland, we've got some norms. It's called the trade norm. And there they say about 80% of the people should get an appointment, a new appointment, within 3 weeks. So where we're aiming at is at least between be lower than those 3 weeks. And you could say this is fine over here. I told you about the specific appointments we have concerning the insurance company, for example, on knee problems. So we also monitor those patients with knee problems with a special appointment code. And there we made the appointment for the knee problems that they should be seen within 2 weeks. Well, over here we look again at the 75% line, and they are seen within 7 days. So over there we're doing fine. This is partly looking backward, but we're also going to look forward, because we can show the medical specialist that in this graph we have his consultation appointment places actually for the next week. So each bar represents the number of consultation places at his consultation hour. And when it's dark green, it means there were some overbookings. So he put 2 patients on one place, or he worked till 6 o'clock. And the past weeks, we've seen that there were some overbookings. For the next weeks, the red line is actually the current state. The next week is in the future. There we already see for next week we have a problem. Probably our secretary has to work till late because maybe 1/5 of the consultation hours are overbooked. So this gives us already some information. How busy will we get it? Then the weeks after, we see the gray bars. There are some places still free in the consultation hours. Well, that's logical, because when the time passes, the consultation hours, they will fill up. Next to that, we look to the patient inflow. So we have seen how his consultation hours are filled up. Now we have a look how many new patients start their healthcare trajectory, his process, within the orthopedics department. And each CTC start, complete treatment start, which is a kind of care path, but then logistically seen, is shown over here. And the different colors show different groups of patients. So we made distinction between knee problems, hip problems, etc. These patients will finally lead to some demand on the OR, in the wards, etc., etc. So we saw that right after the holiday, all the medical specialists were back. They saw a lot of new patients, and it went down and down and down. Here you see this CTC. So it actually consists of a logistical path with his first consultation. Afterwards, a certain percentage of that CTC will go to the OR, percentage will go to the ward, and a percentage will go to the daycare. And there is some time span in between. This we will find back later in another graph. So keep this in mind. What we see here is that the patients that were started in the consultation hours, they now go to the waiting list for the OR. And the past few years it went down, down, down. So the waiting list, the number of people waiting, goes down. So the waiting time also goes down. And actually, although it goes a little bit up, over here we experience a problem because we can't fill the OR time. And that is also shown here. The OR time we can't fill because we check how many hours do we have available in the OR, the green bars. So that's about 45 hours in the first week during the holiday. These hours they are taken away because it's holiday and we send our personnel on vacation. And then afterwards you see the black line, that means the number of hours we used of the available OR capacity. So you see a pretty big gap, and all of a sudden here the medical specialists say, I can't fill up my time, I give back my OR time. Because I don't want to operate 1 hour, I can't fill it up. And also for the future we have a look and we see the operation hours are not filled up. So we have already now a few signals. There's something going wrong with those orthopedics. The number of patients and capacity demand will go down. Here on a day level. This was partly looking backward, but we also want to look forward. So we use that CTC to predict actually the OR time he will need. So all those patients started in the past, we can actually showed them in this graph, based on their care path, that he will need in week 46 12 hours of OR capacity. So this line shows the maximum OR capacity we have, and all the bars mainly are under that maximum capacity we have. So medical specialists, you won't fill up all these gaps, although here you have some waiting list, which you can use to fill up those other gaps. So signal 3, 4 to show. Then you can ask the questions, what can we do to solve this problem? Like I told you, it's difficult to ask him to give back in advance. If the moment is right there, we see tomorrow we can't fill it up, then he will say, you can have it back. But actually what we want from him is to tell us maybe 6 or 8 weeks in advance, I probably won't need it. And then you've got the time to give that operation time to someone else. Our planning horizon of 4 to 12 weeks. What we propose, 6 weeks of OR reduction, about 7.5 hours per day, and create at the same time some extra OR capacity. Now, the medical specialist was first not very enthusiastic, but since we could show him that, like you just saw, that it would not affect his production, he was fine with it. And then afterwards, after 2 months about, we saw the results. His number of CTC starts, so there's new patients that start, they went up. His access time to the outpatient clinic went down to about 2 weeks. The work in progress, so the patients waiting for the OR went up. So the planners for the OR, they didn't have any problems anymore. The OR use went also up. We don't see that the medical specialists give back the OR time 2-3 days in advance. He just fills them up perfectly. And at the end we see that although there was a small dip since he gave back his OR time, the ward is filling up also again. What do we try to do actually with this? At an early stage we try to get insight. What capacity use do you need and what will you need? We give them temporary OR reductions so that he's sure that afterward he improves everything. He can work as usual. And by this actually we gain an efficiency in the OR of the medical specialist and of the wards. Now, for so far the graphs we show. Now I'll tell you something about the tactical planning and also who's involved. Because our main aim was to match the demand and supply and optimize the available capacity. You need the right people to do that. What you saw is the trend analysis and the forecast we were doing for the OR. Later on we go to the optimization. This trend analysis, they're actually done every 2 weeks. So me as a capacity advisor and a few colleagues, we actually every 2 weeks we make a selection of these graphs and these important trends that are happening and problems and causes that result to low capacity use. Afterwards, after this preparation, we discuss them with the managers. So the most notable stuff we talk through with them, and we prepare some scenarios to discuss with the medical specialist. Because the whole aim of this is that we try to involve the medical specialist. But to involve him, we should have good and enough information to talk with him about it. So actually first in the pre-tactical planning meeting, we double check the data we have and we propose a plan for him to efficiently use his capacity. Then afterwards, the Tuesday afterwards, there's the real tactical planning, which also takes place every 2 weeks. And this tactical planning consists of the medical specialist, the director of the hospital, one of the capacity advisors, and a few of the managers concerning the different capacities. Over there, let's say, the decisions are made for this mid-long-term planning to gain some efficiencies. Who are in those planning meetings? In the pre-tactical planning, like I said, the coordinator of the admission planning, that's someone who's in charge on an operational level to arrange that everything goes well. The manager of the admission, excuse me. The manager of the admission planning, the coordinator of the OR, the manager of the OR, and also the manager of the clinics. Then at the tactical planning meeting, also important is that we also have the manager of the admission planning over there, together with the medical specialists. And those medical specialists were put forward from their specialty, and they can actually decide on capacity. So if we propose to take back 1.5 OR, he's in charge to say, okay, I'm fine, I'm convinced with all the data you show me, and I'm sure this will lead to better capacity use for our specialty and more efficiency. Over there, we reached the main change, because it's actually a change of culture. Before, I don't want to give it back, and we were checking afterwards. Now, we kind of try to look forward and let the medical specialist actually participate and decide himself. The most important thing when you set up, for example, this new tactical planning setting, good preparation of data is important, but also decision force to actually be able to make those decisions is important. So we had a director of the hospital to say, we're going to do it this way. Are you all fine? Yes, because that medical specialist is fine to say, it seems pretty good, but if he says at the end, yes, it has to be this way, his colleagues could say, what's stupid of you, we don't agree. And now he has someone to say, hey, it was the director of the hospital who actually wants it, I agree, but it's not really my fault. Although we run out of time, I give you a quick view on some second level of tactical planning, and that is mainly how can we optimize the capacity, so that's more integral view. This is probably a well-known graph of the orthopedics, of actually the wards. So we see the number of hours the patients are laying in the wards, and in the weekends we see always those dips. Logical, because we operate 5 days, then during the weekend we don't see elective patients, and then on Monday we start again. So these fluctuations are common. What we actually did is that we made some new schedules for the OR, some blueprints, in which we actually tell the medical specialist, on Monday you better operate some hips, because that will result in a better use of the OR. Well, before you can reach this far, I told you, you should actually first have basically implemented phase 1 of the tactical planning. Since they had some trust in us to do this, they were fine letting us test this new planning concept, and that resulted at the end at a 10 to 20% reduction of the ward capacity, mainly by flattening those peaks and those gaps in the wards. That blueprint is nice, but you should realize you won't be able to fulfill to it 100%. So our planners, they try it, but they only reached up to 80%, 70 to 80%. The same we did for the urology. Before the setting, that with a big peak on Friday, now we changed schedule, we put them on a different OR day, and all of a sudden in the wards it's much more evenly spread. Finally, the results of what we did, like I told you, we started in 2008. We could close down a ward in 2009, mainly because of length of stay reduction, but also better spreading the capacity and taking out unused capacity. The waiting time of the OR, we brought it back down, and also the OR use, you see. The first year we gained 5% more operations. The maybe strange thing, you think, in 2010 is that we didn't gain any OR increase, higher usage over there, but that's logical, because if you reach a certain maximum, you can't go even further. So that's why in 2010 and 2011 our OR use stayed a bit constant. Well, mainly what we did the 2 years afterwards is increase production in the OR, so higher turnover, and in 2011 even reduce the length of stay and the capacity in the wards even further. For so far, to give you the most important points, I think, is that enabled to do these changes in capacity, mainly in a culture that is in the beginning not like giving back capacity, should really try to let the medical specialist participate and also give him the impression, and also it's true of course, that it will also give some advantages to him. If he can do his work on the OR in 1 day instead of 2 days, means he gains 1 day staying in the golf court, for example. The focus is mainly on efficient capacity use, and as a result, there's a financial advantage. But the most important thing is don't focus first on money, because actually money is automatically resulting in, or actually improving your capacity is automatically resulting in money gains. It's a bit like with lean management, you focus on a good process and remove all the waste, and as a result, you gain some money. The transparency we brought into the hospital with this tactical planning meeting every 2 weeks, it really made it more easy to change and do alterations to our different capacities. So the number of beds we assign to certain specialties, but also the number of ORs we opened up. For so far.
So we have our, thank you very much for a very thorough presentation. We have our plenary downstairs in 8 minutes, so I think if there are any questions, Michel can stay up front and you can come and ask him. And I want to thank all of our presenters for a very thorough and interesting presentation. So thank you very much.